Hi, I'm Suneet Mittal for Heart Rhythm TV. We're here at the annual scientific sessions of the Heart Rhythm Society in San Diego, and we're here with Rob Russo, Lindsey Gakenheimer, and we're here to talk about a very important topic at this meeting. Simultaneous with this meeting is a new call to action, a document that's been released by Heart Rhythm Society to address issues that are very important to our membership, and that is MRI scanning in patients with a CIED device. So welcome, thank you for joining me.
Thank you very much.
Thank you for having us.
So of course, we rely a lot on the 2017 consensus document. The world has of course changed quite a bit since that time. Can you tell us a little bit about what led to the thought process of developing this call to action document?
About a year ago, we were inundated by vendor-specific exclusions for many overlap of MR conditional devices. And that led to engaging HRS and then a task force which was formed early last year. At the conclusion of that task force and a survey at last year's national meeting, the board of directors decided it was an extraordinarily good idea to form a committee to write a new scientific statement and a call to action, the things that we need to do today, because access for many was poor, if not non-existent. And therefore, in the last couple of days, there are call to action. Lindsey and I co-chaired that scientific statement writing, and it touches on many areas of patient access.
So one of the things that, at least for us in clinical practice, where we see this on a daily basis, is that in the last decade, the good is, I think we've started to appreciate how safe these MRIs are in these patients, even in populations that initially we were hesitant about. Our imaging colleagues now can basically get these things safely done in patients. So that's definitely a good. But what is really not changed or has worsened is how much infrastructure is required to get these studies done. And largely this conditional, non-conditional thing, often dictated by specific recommendations by industry as opposed to the radiology societies, our societies. So and the survey really showed that our memberships were really being bothered by this issue. So what do you think will be the next steps to really help in that area?
I think things that will be really helpful is engaging together with having the collaboration between international radiology societies and cardiology and EP societies to have a unified voice to advocate for our patients, to advocate for clinicians, to really improve access, to reduce all of these exclusion criteria that are not based on data, and to make policy change to improve access. In addition to streamline workflows to reduce delays in care, to reduce healthcare costs, and also work on improving reimbursement of the time-intensive processes that are involved in these scans.
Yeah, and I agree with you. I mean, I think some of the things that we've been very focused on is, listen, we really shouldn't rely on industry representation for this, and how do we establish an infrastructure to do this? And to your point, Lindsey, for the time and effort it's going to take, how do we get reimbursed appropriately so that we can create an infrastructure that allows us to do this without relying on industry? Does the call to action discuss this issue at all?
Two parts, if you want to take that part of it, and I'll...
Absolutely. So fortunately, starting January of this year, there have been new CPT codes that have been introduced to improve the reimbursement process. You can see them in the call to action document. We have outlined them we can now get reimbursed if there's written documentation of an assessment of the risk, and as well as a notification or certification that the risk is appropriate and the patient can undergo the scan, as well as any modifications that a radiologist needs to do for the scan. Those are all reimbursable for at the moment, which is really, really great that we have this. However, it doesn't address though that there's still just discombobulated care that really exists as far as allowing a patient to then undergo an MRI, just this poor communication, I think, between radiology, between EP, and really a discohesiveness that I think still needs to be addressed, as well as I think we still need to make some additions to the CPT codes. I think it's important to also recognize that with any conversation that is had with CMS about modifications to reimbursement codes, that we also make sure that we do not undo the great work that has already been done to make some really great progress in this avenue.
One thing we uncovered in writing a statement is the explosion of guideline documents by many national and international societies. And what we've advocated at the HRS level is, number one, creating a certification process for centers of EP and radiology cooperation of a very small number of people, number one. Number two, give them a pathway to follow rules to remove any concern that a radiology center would have in not doing things appropriately. Next, and very, very important in this process, is removing the industry representatives from the decision-making process, from patient observation and reprogramming, a role that they never wanted to be in. And certainly not only is it costly for industry, I think it puts them in a very unfair position of clinical responsibility that they should never have shouldered.
Yeah, and I would also add, it's really important for patients to be informed that these scans can be done safely. It still really pains me when I hear a patient who has not sought a much needed MRI examination because they have been given the impression that it just can't be done. And I think we have a lot of work to do in this area.
A notable case is a patient in Australia who contacted me because they could not get a scan in any of the centers within that continent. She flew to San Diego, got off the plane to exclude the diagnosis of ALS.
Wow.
And then got back on a plane back to Sydney, fortunately with a normal brain scan. While that's an extreme, every day there's somebody who cannot get adequate access. And I don't ever want to see somebody hurt because of an inappropriate or incomplete diagnosis.
Yeah. So I heard from both of you the critical need for societies, our society, to work, with the radiology societies to really make this happening. Can you inform our audience, what efforts are being done for Heart Rhythm Society to actively have those engagements with radiology?
Yeah, I think that the first step is to begin conversations. We've been reaching out to the Radiology Society of North America, as well as reaching out to ISMRM to start conversations to make sure that we are having sessions like this at HRS, and similarly at radiology sessions. We should be at the table. We should be having presentations, engaging the discussions. I think the first part is having the discussions with everyone at those meetings, and then from there we can continue to build out our plans, our policy actions. So start with conversations.
But as soon as the certification process is in place, with half-day courses at all the national meetings that cross over to both genre and disciplines, then I think radiology will no longer feel like there's a responsibility or a litigious basis to how they scan, follow, deny, or allow access.
So I'll end by asking both of you to speculate on something, which is how far in the future do you think it'll be when this is a fully automated and standardized process where we're really not talking about it? We have, systems to be able to do that. And to get to that point, what is going to be the critical breakthrough that's needed to get us over the hump at this point?
I thought in 2017, when we published MagnaSafe, in 2018, when Medicare published the NCD update, that our job was done. I never thought that 8 years later we'd be having the same conversations of playing scientific whack-a-mole of, what about this or what about that? I think this pathway will finally end in the certification process, in the removal of unnecessary responsibility from radiology. And as soon as we get the device reps out of the equation, it'll be part of everyday workflow, don't you think?
Agreed, fully agree.
Well, I want to thank you both, Rob and Lindsey, for this incredible work, as well as all the co-authors on this document. I think this is absolutely a critical issue for our members. You clearly heard that from our surveys. And I think anything that has such a pain point today that we can help improve is definitely a value add to membership. And I thank you both for your efforts in this area.
Thank you.
Thank you.